Thanks, Enrico, and thanks, Dr. Veith, for putting together such a great program. So this next segment of the program is going to be more on TCAR, and I'm sure people will be coming in from the break. But this is kind of an interesting topic in the following manner that really the TCAR question has been, can we get the low stroke rate of CEA along with the low rate of cranial nerve injury and MI seen with transfemoral CAS? And is there a way to produce that outcome for our patients? And that's really been the TCAR question. And now as we gain more data, the question becomes, can we extend it to certain subgroups of patients that may not have been intuitively the ones that we would want to treat first with a newer technology like TCAR? So with respect to contralateral carotid artery occlusion, it did not strike me necessarily as the right group to begin with. They have a higher burden of atherosclerosis, more coronary disease. Hemodynamic instability is riskier in this group. Both hemispheres are at risk when you go to fix one. And there have been some data that suggests that with endarterectomy, in this 4.2% in patients with common carotid artery occlusion and 2.5% in those without. Another study, 3.7% with and 2.2% without. So just suggesting that the contralateral common carotid artery occlusion causes an increased or poses an increased risk with endarterectomy. So what does the data say? Well, in this publication from the Journal of American College of Surgeons, the stroke and death risk in the VQI with CEA and TCAR were different, and it was 2.8% for CEA and 1.5% for TCAR, stroke and death in the VQI. And when you look at these patients, separate them by way of symptomatology, the stroke and death risk in the asymptomatic patients, 2.5% with CEA, 1.1% for TCAR, and in symptomatic patients, 4.1% versus 3.4%. So all of these things suggest that TCAR can be done safely in patients with common carotid artery occlusion on the other side. Here's just one more study looking at stroke and death in hospital outcomes in a larger group of patients. About 10%, 10 to 11% of the patients in the VQI TCAR registry have contralateral common carotid artery occlusion. And then again, with asymptomatic patients, stroke and death between those with no common carotid artery occlusion and those with is about the same. And in symptomatic patients, same thing, except that it appears that when you do a TCAR early, there is an increase in risk compared to later, but this is only based on a small number of events. So I think this is still under study about the very early period after stroke. And I'm going to actually get to that in just a moment. And then in the Roadster 2 trial, again, approximately 10% of the patients had contralateral common carotid artery occlusion. And in that group, depending on how you look at it, the intention to treat or the per protocol, there really was no difference between the two groups. So what about symptomatic patients? Well, we know from CREST that the rate of stroke and death after CEA was 3.2%. We also know that in symptomatic patients in the VQI that it appears to be very similar, the results of stroke and death between CEA and TCAR. So what about the recently symptomatic? Well, obviously it's going to be unstable plaque. Early CEA appears to be relatively safe, but very early CEA has been reported in different series to have an increased risk, like in the Swede VASC, where if it was done at 0 to 2 days, the stroke and death risk was 11.5%. So these are in-hospital outcomes now for TCAR, and you can see 0 to 2 days has an increased risk of 6.5% stroke and death, but other early, 3 to 14 days versus longer term, no difference. I will just point out one of the problems with very early TCAR, like very early anything, is that the patients frequently are not medically optimized. In this case, the very early 0 to 2 days only 3/4 of them were actually on dual antiplatelet agents, which we know is really necessary for TCAR. So in conclusion, TCAR appears to be very competitive with CEA, and now this competitiveness, if you will, is being extended to other groups like those with contralateral common carotid artery occlusion and also the symptomatic and the early symptomatic patients. Thank you very much.